Hi, welcome. Thanks so much for joining me. My name is Michelle Moser. I'm a clinical liaison with Revelation Pharma and also Makers Compounding Pharmacy. In this session, we're going to talk about autoimmune diseases, kind of where they come from and how do you treat them, because they're all a little bit different. Unfortunately, autoimmune issues tend to be growing at this point in time. So we're going to really do a kind of a deep dive into what's really going on. I'm going to talk a little bit about compounded medications, and certainly this session is for informational purposes only. At this point in time, there are well over 40 different identified autoimmune diseases, but recently I heard a practitioner actually speak on that there were well over 100. So I haven't been able to really verify that. So I just wanted to note 40, but my gosh, it's really unfortunate that over the past half century that things have really blossomed and not necessarily in a good way. However, there are ways that we have identified through scientific research, different ways to evaluate and enhance outcomes rather than having to just sit down and be told, well, there's really not much we can do for you. Well, there's a whole lot we can do. What we're finding is that autoimmune diseases usually come in sets. Sometimes there's 2 or 3 or 4, rarely is there just one. There may not necessarily be all diagnosed at the same time, but they do tend to crop up over time. We also see that there is a very close correlation as to what's happening in the gut, which kind of makes sense because when you take a look at how the gut actually performs and where most of our happy hormone and also our other chemicals and nutrients are being absorbed from and how they're carried around through the body, the gut really needs to be very healthy for us to be healthy. What I've seen throughout a lot of research that I've read through, one of the first and foremost things that they talk about is all of these practitioners, all of these scientists that are talking about autoimmune disease are saying you've got to remove grains from your gut, or from your diet. You've just got to get rid of all the grains. And I find that interesting because we're so focused on being gluten-free, but what really is gluten-free? Some people think, oh, well, it's just wheat. Well, it's definitely more than wheat because gluten is also a part of other grain species like rye. But if we can remove all grains, including corn from the gut, we're also decreasing the amount of GMO substance that we're taking in, which will decrease the amount of inflammation throughout the body and then also help the gut to improve as well. And I'm going to talk a lot about low-dose naltrexone as we get into further into this session. I love this slide because it really shows how autoimmune disease is more than just one part of the body. You know, we could have Hashimoto thyroiditis or Graves, and quite honestly, a lot of people are both. They're not 100% one or the other. They are kind of on this roller coaster ride of things. But what we also know is that when someone has other types of autoimmune disease, it can definitely lead to other areas that are dramatically affected, whether it's in the skin, in the nerves, in the blood, especially in the GI tract, which can then very easily connect with the brain as well. But even when we're talking about rheumatoid arthritis, polymyalgia rheumatica, all kinds of other bone issues, most of those are not necessarily the first and foremost diagnoses, but are subsequent after other diagnoses of other autoimmune disease. But what this all boils down to is that we can't separate one part of the body from the other, because when we don't feel well, if we're hurting, that's going to affect our emotional state. That's going to have an impact on family, on work. And certainly, do we really feel like getting up and exercising or going for a walk? So all of these behaviors have a very close correlation as to what's actually going on in the body. And what this boils down to is productivity. And in the United States, we're very focused on productivity, whether it's outside of the family or within the family. What we also see with autoimmune disease, and I try to add as much citation as absolutely possible through these slides, is that it's a combination of a variety of diagnoses, but we're always seeing inflammation as a part of this, whether it's rheumatoid arthritis, specifically TNF alpha, interleukin 6, interleukin 1 beta, interleukin 8. But even when we take a look at MS and some of the autoimmune diseases associated with the nervous system, we see very similar cytokines and immune dysregulators. Again, those interleukins, tissue growth factors, tissue necrosing factors, all of those are associated with even non-autoimmune diagnoses, whether we're talking about Alzheimer's, Parkinson's, ALS, all kinds of even psychoactive disorder as well. It's very interesting how all of this is associated with inflammation, and the same cytokines and inflammatory markers tend to be associated. What we also know is that there tends to be a vitamin D deficiency. Often there's a viral infection such as Epstein-Barr, Lyme. Of course, we know that smoking significantly impacts the autoimmune system, and it can very much damage a wide variety of other receptors as well. Often there's a hormone imbalance, and it's not just the sex steroid hormones, but it's also those hormones such as melatonin and the thyroid. And we really need to pay attention to T3 because that's the only active form of thyroid. But even the other hormones such as insulin and neurotransmitters. And we do call the standard American diet quite sad, because the nutrient deficiencies that we're seeing now are much more pronounced than what they were 50 years ago. And that's because of how our foods are being grown, how they're being prepared, and our busy lifestyles. We also know that, going back to the sex steroid hormones, that estrogen, progesterone, testosterone have a very key active role in modulating the immune system. And that's been identified by a wide variety of scientific research. But all of these will impact autoimmune disease and their progression. It's also curious that women have more autoimmune diagnoses than men. And I'm very fascinated by this because I do believe that it has to do with our complex hormone lifespan, specifically because we tend to have more symptoms associated with low hormone levels versus higher hormone levels. We are just that much more complex. And of course, with everything that we go through with childbirth, being pregnant, the childbirth itself, working as moms, working as professionals, and then even going through perimenopause, menopausal years, that roller coaster of hormone changes can be a little daunting. There's a wide variety of triggers for autoimmune disease as well, and most of these have a dramatic impact on the gut. Many of these triggers are associated with diet, stress. Stress affects every part of the body, even the gut. Hormone balance. Hormone imbalance is very pronounced. There's estrogen receptors in our eyes, on our skin, in our gut, everywhere. Exposures to pathogens, whether those are pathogens that are viral in nature, protozoa, perhaps even other parasites. And those are separate from the environmental toxins that we are also faced with every day, whether it's associated with paper or the air that we breathe, anything. Some homes have more mold in them these days than what we saw in years past, but also the lack of sleep. And that's where stress also plays a big role, right? But also hormone imbalance as well. So if your thyroid is off, if your sex steroid hormones are off, your melatonin perhaps peaks at a different time of day than close to bedtime, that's all going to play a very vital role with sleep. And even the psychological stressors that we go through on a day-to-day basis. And one researcher that I was listening to at a functional medicine platform specifically said that even stress prolonged for more than what we would term a few minutes can have a significant impact on the absorption and the lining of the gut. That I think is very interesting, because a lot of times if I'm talking to patients and I say, describe your stress, describe how things are. Oh, the reactions that I get are, oh, I'm not stressed. That's just what I do. This is just life. And truly, she's carrying 5 or 6 hats around, right? So she's a taxi for the kids. She's a cook. She's a cleaner. She keeps the house clean. She takes care of the animals. She's a professional. She works and does a little bit of everything. She even plays nurse at times, I'm sure. And all of this will dramatically impact all of these areas. But even medications that we are prescribed or are available over the counter can either deplete very important nutrients, which can lead to a variety of triggers that can impact autoimmune disease, but can also change the way the gut is going to react to things, as well as perhaps those medications specifically are causing the gut to be leaky to begin with. The gut lining is only 1 cell thickness. So if we're going to have a positive impact, we need to make sure that whatever we're putting in our gut is being handled appropriately, and that we have enough nutrient to be absorbed, but then also be able to be carried out throughout the body. Genetics versus epigenetics versus environmental. A lot of times we hear that, oh, well, it's all genetic. That's kind of the way a family was raised. And it's just kind of handed down throughout the family tree. But is it truly genetic? And if you're born with a set of genes, do you have to turn those genes on? I don't know. But there's a wide variety of environmental impact that we also need to take into account. Is someone raised in farmland versus in an industrial area of a city or in an urban corridor? All of those are going to have very different impacts on the human body, but specifically the outcome of what could be an autoimmune disease. And just because you're born with a set of genetics doesn't mean you necessarily have to succumb to those as well. And there's a wide variety of really great testing out there now that we can identify those mutations in certain genes and then decrease the impact that may have, or literally, instead of turning it off, maybe turn it back on, or vice versa. There's a wide variety of things that we can take a look at, but we don't necessarily have to settle for the diagnoses or the verbal outcome of, oh, well, it's just genetic. Well, we don't have to settle for that. One of the best platforms that I've seen for genetic testing is a product called 3x4 Genetics. And there's a wide variety of practitioners that have studied under 3x4 Genetics to really understand the entire platform, but also how the the results can be read, and then the information delivered to the patient. What I love about this is that it's very simple. It's literally just a quick cheek swab. It can be mailed directly to the patient, and it comes in this really interesting packaging that is really nice to look at. It's pleasing to the eye. It's very carefully details exactly what to do and how to perform the test. Prepaid postage envelope comes with it as well. You literally pop it back in the mail and get results in a few weeks. But it looks at 36 core insights that will determine what's going on with the brain. How healthy is that? What about our nutrient status? What about those metabolic pathways that are happening in the liver and elsewhere? Overall, what does our inflammatory profile really look like? What about organ health? So how does all of this then play into what are our organs and how healthy are they right now? Of course, that takes a look at hormone levels as well. But even such things as, do you metabolize caffeine very well? How do you do a salt? And even what type of impact exercise is best for you and your genetics? That's what I find very, very helpful, so that we can literally tell a patient, perhaps all of that cardiovascular work that you've been doing, all that cardio work and that high impact exercise may not necessarily be the best for that individual. Maybe it is great for another individual, but perhaps the person that's in front of you may need to perform more yoga or Pilates and again, still strengthen those muscles, but yet have more of a calming effort. And what's also interesting is that when we take a look at salt metabolism and caffeine metabolism and how both of those can have impact on what is going on hormonally, but certainly other basic indicators, I guess, basic health indicators that we take a look at, such as blood pressure, what's happening with cholesterol and things like that, because those are key areas of health measurements that we take into consideration every time we look at the patient. And we have to conduct those tests at least annually to really ensure that things are on the best track. But there's such an impact and connection between what is happening in the gut versus the connection to the brain. Of course, we know that the gut makes those medium chain fatty acids that are fuel for the brain. But specifically in 2014, which wasn't all that long ago, there was some published research that showed that gluten and casein resulted in release of peptides that can cause changes in the epithelial cells of the blood-brain barrier, as well as the GI tract, which can result in increased inflammation. That's very interesting, because some people will ask, well, is being gluten-free or dairy-free, isn't that just a fad? I mean, really, is it really that impactful? And maybe I'll just have a little bit here and there, but for the most part, I'm primarily gluten-free and casein-free. But what we also note, not only in Dr. Perlmutter's book, but also with other research, is that a gluten molecule can substitute on the thyroid and can be interchanged for thyroid molecule, but yet it has absolutely no activity. And what we also know is that the gluten can serve to initiate and potentiate the process of inflammation in autoimmune and neurological disorder. Very interesting. So really, is what we're eating the best that we can do for ourselves? Should we be 100% gluten-free? Well, I do believe that that is the case when we're looking at very specific autoimmune disease, such as Hashimoto thyroiditis and Graves' disease, because we know directly that there can be some significant impact of gluten on the thyroid in worsening that autoimmune disease. This is a gut test that literally takes a look at the complete DNA sequencing of everything that's going on in the gut. It's a stool test. Again, very easy to perform, very easy to understand the results. It breaks it down into the family and the species of everything that's going on in the gut. And it will literally compare that to kind of an average American for your geographic location, I guess is the best way to put that. So whether somebody presents with IBD, leaky gut, insomnia, bowel overgrowth, even things like depression, weight gain, hormone imbalance, especially those individuals who desperately trying to lose weight and they just can't seem to pull it off. Well, this is one way to actually get to the bottom of it. I had a gentleman who came into the pharmacy who was really working hard to get his A1C down. He was having great difficulty getting it below a fairly elevated amount. So I think he was around 8.5. And he says, I'm eating like a rabbit. I'm eating a lot of raw vegetables and salad. He says, my salad at lunchtime, I put quite a bit of protein. So I usually do chicken or tuna and some seeds and nuts, and, doesn't really add a lot of other things to it. He uses vinegar and oil for a dressing. And what he eats for breakfast is a little bit of protein, some berries, and does have coffee and does drink quite a bit of water throughout the day, and then has protein for dinner, several vegetable, etc. But what we found is that because he was lacking very specific good bacteria in his gut, he was having a hard time maintaining a good A1C below even 7, let alone below 6 or below 5.5. He said that he hadn't been below 6 in decades. But what he did know is that the inflammation from having high blood glucose levels was really affecting his joints. He was achy all the time. It was causing depression. He was having a hard time sleeping because he just couldn't get comfortable. But it was absolutely impacting his energy level and his ability to interact with family. So after we did this quick Biome FX gut test, we identified what was lacking. And what we also found is that because he had high average amounts of other fermenters, when he was eating a raw diet, it was actually being metabolized and turned into sugars because of the ratios of some of the good guys, but also some of the bad guys. We literally took him off of most raw and did either oven roasted or gently steamed, and made sure he still had really good sources of protein. And literally just within a few months, he was able to pull his A1C down. His energy level spiked. He felt fantastic. It was very interesting because he hadn't been able to get any answers anywhere else other than when we went to one of the foundational or root issues and did a little bit of testing and was able to show him in living color in, I think it was a 21-page report, exactly how he could change his diet a little bit. We added some nutrients, but really he was able to make a dramatic impact on his life. And of course, when we're dealing with Hashimoto thyroiditis, this is a very common diagnosis, especially in the Pacific Northwest. We see a lot of Hashimoto thyroiditis. It's primarily in women. Not always is Hashi the only autoimmune disease that is being diagnosed. A lot of times there's a fibromyalgia, a chronic fatigue, perhaps a Graves indication as well. Sometimes there's some other issues as well, other health components, a lot of aches and pains. And again, there's dietary concerns even with Hashimoto thyroiditis. And so genetically, do you form oxalates? So when you eat certain foods, do you actually metabolize those and form oxalates that are maybe not necessarily cleaned out by the liver and the kidney? Well, that can cause inflammation and cause a lot of pain and suffering. But what we also find is that we can use medications like low-dose naltrexone to help manage the autoimmune thyroid condition, improve antibody status, and help to normalize thyroid function. And it does this by increasing endogenous beta endorphins and metacatecholins, also the opiate-derived growth factor and its receptors on the thyroid cells. The immune modulation through toll-like receptors, usually toll-like receptor 4, and also T cells. So all of this during the immune modulation process will actually lower antibody numbers. So whether it's thyroid peroxidase or the thyroid globulin, those usually come down. So whenever somebody starts on low-dose naltrexone and they have a diagnosis of Hashimoto thyroiditis or Graves' disease, or even any known thyroid disorder, it's always a good idea to redraw those labs, perhaps 4 to 6 weeks after the initial increase in dose or titration schedule for low-dose naltrexone. Of course, every disease state is formed in inflammation. It tends to be the root cause of almost all disease, whether we're dealing with autoimmune disease or even just kind of generic disease or general disease that people are diagnosed with, whether it's allergies, as you can hear. Even when we go down to obesity, there's a lot of inflammation associated with that. Even psoriasis, whether it is fungal or yeast in nature that causes inflammation throughout the body. Cardiovascular disease, of course, absolutely inflammatory. Even when we're taking a look at bone issues, whether it's osteopenia and osteoporosis, either one or both, they are both inflammatory issues. So anytime that we can make an impact and decrease inflammation, I think we're going to have a better patient outcome. So just some quick facts. About 30% of Americans are affected by chronic pain. Of those 30%, we hear quite a bit of issue with head and neck, but usually knee and low back. And I'm curious as to why that is, but really, head and neck, then we hear a lot about migraines and chronic headaches. And knees, because, well, we do a lot with our knees. Not only do they support the majority of our weight, but we are bending them all the time. And of course, if we're running or performing any kind of exercise, there's going to be a lot of impact to the knee. But even in the low back, a lot of it tends to harbor there. And that a lot of times has quite a bit of inflammation due to neurological disorder. And then how the nerves will leave the back and go down the legs. When we're looking specifically at autoimmune disease of the gut, Crohn's disease is one of the most common autoimmune diseases of the gut. And this is an article from, I believe it was 2007 here. And this article specifically looked at low-dose naltrexone and how it improves active Crohn's disease. So these individuals were increased from a lower dose up to 4.5 milligram low-dose naltrexone, and they were kept on that dose for 16 weeks. 89% deemed responders with average decrease in the CDAI score of 70 points. And 67% achieved disease remission, which I believe is absolutely significant, primarily because Crohn's disease is one of those autoimmune diseases that has a dramatic impact on life. People tend to have a wide variety of bowel disorder. They don't absorb their nutrients very well. They tend to have changes in their weight up and down. They're usually tried to control with steroids or a wide variety of biologics. And low-dose naltrexone does play well with certain biologics, but we have to be careful in which order they are actually initiated. In this study, biologics were not used, although many of these patients were on steroids, and those steroids were able to decrease over time. Of course, balance is key, no matter what we're talking about. But when we're talking about hormones, it's very important to balance those because of how the hormones will modulate the immune system. They can be out of balance at any age and due to a variety of circumstances. So we can have hormone imbalances at menarche, even through our teens and 20s, especially into our 30s, whether someone is pregnant or not pregnant. Those are a wide variety of hormone changes. But then as we get a little bit older and hormones tend to decrease with time, that again is going to cause even more imbalance, whether we're in premenopause, perimenopause, or even menopausal times. There's a wide variety of testing that can be done. It's not terribly expensive, and almost all of it is very, very easy to do. And there's a huge difference between salivary testing, serum testing, and urine testing. And when to use it is very specific to what exactly it is that you're trying to look for. So saliva is a passive migration of hormone through the salivary pool and is a really great way to evaluate baseline, but even continual application of where the hormones are at any given time. If someone is menstruating, if a woman is menstruating, it's best to perform the saliva test on day 19, 20, or 21 of her cycle. And we see better results of hormone value associated with true cellular value with saliva versus serum. And the reason is because serum is primarily a water base, but hormones are oils. So they're dependent on sex hormone binding globulin or the carrier proteins to carry those hormones out of the serum into the target tissues. Whereas saliva, that too is a salivary pool of water medium. However, it is a passive migration more closely monitored to a cellular level. And of course, a urine evaluation is going to give us that amount of metabolized hormone that has already been through the body, been through the liver, has exited the kidney and or the bowel. And now we're taking a look at exactly what's left over. So genetically, and taking a look at liver function, exactly what is she doing with her hormones, or him, and what are they doing with it at this point? So it gives us some great valuation as to, are the metabolic pathways clogged up? Are we metabolizing more toward the 2-hydroxy, 4-hydroxy, 16-hydroxy, the good, the bad, the ugly? And we can manipulate that. So if we know how this is being impacted, we can make choices and we can then change things up a little bit and perhaps correct symptoms, maybe even have an impact on autoimmune disease, but certainly have an impact on overall hormone health. But once we know what is actually in the body, then we can really take a look at what needs to be replaced, what is in excess, because a lot of times a lower level here versus a higher level over here might actually yield the same set of symptoms. And that's where it gets a little bit confusing and perhaps a little complex. But if we test, then we know. And then we can adjust the dose based on the time of year. If someone their vitamin D levels are higher, their melatonin is changed, perhaps they need less hormone. So therefore, less hormone in maybe the summertime versus the wintertime. It also changes because exercise is different, usually in the summertime versus the wintertime. Perhaps that is also we could adjust dosage based on age and weight and dietary circumstances. And of course, there's a wide variety of ways to actually apply any hormone that is necessary. Of course, we never want to exceed what is a physiologic dose, and not everything has to be oral. So we can apply things topically through the skin. We have a wide variety of commercially available products that are available in a few dosage forms, mainly patches, but there's some gels available as well. But when we're talking about compounding, we have a much larger breadth of dosage forms to choose from that are going to really fit with that person's lifestyle much better. Menopause. Well, what do we have to say about menopause? Perimenopause, premenopause, menopause. When there's changes in hormone fluctuation, we usually see pro-inflammatory times. It's really unfortunate, but we tend to see that. That can also change neurological system, and it can also change outcomes completely. When we understand hormone levels, we can have a greater impact on that. It's also very interesting that a lot of autoimmune disease is diagnosed in women mid-30s to 60 or 70. And that's really pre or perimenopausal time through menopause. The perimenopause tends to be a pro-inflammatory, and disrupts estrogen-regulated neurological systems. Estrogen is a master regulator that functions through a network of estrogen receptors, subtypes, alpha, alpha, and beta. And these receptors are shown to regulate a key component in the innate immune response, known as the inflammasome. And with that, it's also involved in the regulation of neuronal mitochondrial function. Of course, if we understand how the mitochondria are functioning, we can have a great impact on that. We can use very specific nutrients to have an impact for the positive, but then we can also perhaps even minimize symptoms to help the patient feel better. The concentration-dependent effects of estrogen on the immune system, the role of progesterone, androgens, leptin in the gut, oxytocin and prolactin, and the interplay between T helper cell 1 and T helper cell 2 immune responses together maintain a delicate balance between host defense, immunological tolerance, and autoimmunity. What's also very important is that we know that low-dose naltrexone can actually have an impact on Th1 to Th2 response. And in this very specific article review, multiple autoimmune diseases were analyzed in the context of each of the three endocrinological transitions in women. Evidence was provided from human epidemiological data and animal studies that endocrine transition exert profound impact on the development of autoimmune disease in women through complex mechanisms. Wow, that's a lot of information. But what we also know is that by looking at the cytokines and looking at those pro-inflammatory markers and also understanding where the hormones are with that, we can make changes and dramatically limit the effects of an autoimmune diagnosis. And we can do that by hormone evaluation, as well as using low-dose naltrexone to reduce those pro-inflammatory cytokines, specifically interleukin-6. So interleukin-6, 10, and 12 tend to be the most pro-inflammatory cytokines, and LDN has a dramatic impact on those. So does estrogen. But estrogen also is one of the last hormones to actually change much in menopause. Usually progesterone drops off first, testosterone tends to drop off second, and then eventually estrogen will fluctuate quite a bit. But when someone is having significant issues, the first thing that they do is add estrogen, but they do that without really testing. But if we knew where foundationally things were, we could probably make better choices for medication therapy and outcomes. What this study, again, goes on to take a look at is exactly what is the impact of sex steroid hormones and menopause related to autoimmune issues. And are they worse during perimenopausal and menopausal times? And the answer to that was yes. And it had a lot to do with hormone fluctuation and the impact of those hormones on the immune system, and then also the development of pro-inflammatory cytokines. But we can't forget the guys, because the guys also have a wide variety of autoimmune issues. And men too have hormone fluctuation, which we lovingly call andropause. Primarily it's testosterone, but testosterone is metabolized to estrogen unless it can be blunted. And then we can actually change that. So when we're evaluating hormone level in men, it's important to take a look at all the hormones, just as we would in a female. So looking at testosterone, the metabolites, specifically dihydrotestosterone, but also looking at estrogen, progesterone, and sex hormone binding globulin. Sex hormone binding globulin is that carrier protein that carries the hormones around and will preferentially bind to testosterone. So if that's elevated in a high estrogen situation where testosterone may be lower, then we can actually see issues of cardiovascular disease, pro-inflammatory issues, elevated blood pressure, changes in coronary artery disease, prostate disease, as well as diabetes, because usually with diabetes, testosterone tends to be lower and estrogen can be a little bit higher. But again, this is when we also see the diagnoses of a wide variety of autoimmune diseases. So I've talked a little bit about low-dose naltrexone. So what exactly is it? So if you're not familiar with LDN, it's naltrexone was actually developed and FDA approved back in 1964. It was a medication that was developed to turn off morphine. So back in the early 60s, the FDA said, look, we know we've got all these medications out here, but we have to prove that they're safe and effective. And we need to understand their mechanism of action. So in order to do that, they had to develop other medications that would literally turn off certain things. So when they were evaluating morphine had been around for quite a while, they needed something to kind of like turn it off. So they developed naltrexone. And what they found is that naltrexone will bind to those same opiate receptors, the mu, kappa, and delta receptor, and literally block that. And it will, therefore, morphine won't be able to bind to those receptors either. But over time, and specifically in the mid 80s, there was a wonderful physician who is Dr. Bahari, and he was treating a wide variety of AIDS patients. And the AIDS patients that he was focusing on, unfortunately, were also alcoholics. So we knew that naltrexone worked well for alcohol overuse syndrome, and so he would prescribe that. We didn't have a ton of drugs back in the mid 80s. It's like we do now. There's many, many more out there now. But what he found is that these individuals were literally breaking up their doses because they had to pay out of pocket for a prescription. So we didn't have a lot of insurance coverage back then either. And so they were breaking up their doses to make the medication last longer. And what he found is that when they got down to quarter and eighth pieces of these 50 milligram tablets, so anywhere from 6.25 to 12.5 milligrams, he noticed that their T cell counts were improving in HIV patients. And that wasn't seen before. He literally had an epiphany in the middle of the night as to how that was working. Well, what happens is that LDN works on several different mechanisms. But one mechanism of action, literally, it helps to modulate the immune system. So it literally will block the endorphin receptors, and we upregulate those to try to make more. And then we make more endogenous endorphins, which not only help us to feel better, but also help to modulate the immune system. Intermittently, low-dose naltrexone will block specific pain receptors. And it works at the cellular level, which can benefit almost every disease. Pardon me. Because most disease is derived from an inflammatory state and or a failing immune system. That's what autoimmune disease is as well. We can make low-dose naltrexone in a capsule form, in a tablet form. The tablets can be scored, capsules cannot be changed. But we can make liquids, we can make transdermal gels, we can make liquids and films that can dissolve under the tongue. And we can also make topicals to help with a localized need, but the topical is not necessarily interchangeable for an oral dosage form or a sublingual dosage form. We even have low-dose naltrexone eye drops at this point. All of these are compounded. Nothing is commercially available for this low-dose need. And what we're finding is that these low doses are anywhere from 0.1 milligram up to around, I'd say 3, maybe 4.5, maybe 6 milligram. Of course, low-dose naltrexone is also used for weight loss, and in moderate dosing, anywhere from 4 to 8 milligrams up to 32 milligrams a day, and it's combined with another medication has been shown to significantly impact appetite and help people pull weight off as well, which is also very, very interesting. One of the studies that was put together back in 2017 was through a professor at Dartmouth University. And he had been reading so much about LDN. And what he did is he took the first 900 articles and case studies. Yeah, the first 900 up to 2017 and compiled them and evaluated how the evidence actually supports the use of low-dose naltrexone. So how was the study put together? What disease states were focused on? What methodology did the study actually use? What dosage forms were used? Were there any side effects? What kind of impact to patient health? How many patients actually concluded the study? And what were the doses used, as well as the final overall outcome? It was very, very interesting. What he summarized is that whether we're dealing with fibromyalgia, Crohn's, multiple sclerosis, a wide variety of other non-autoimmune diseases like complex regional pain syndrome, a wide variety of vector-infected issues like Lyme disease, that LDN has a dramatic impact and could potentially help more than 20% of the world's population. So since 2017, we have seen a lot more studies come out. In fact, in the last 4 or 5 years, we have seen probably another 30 or 40 studies and case studies being published. We have seen low-dose naltrexone in a wide variety of pilot studies on multiple sclerosis. There are 2 new drug applications being in trial right now. One is specifically on chronic regional pain syndrome, and the other one is on Crohn's disease, and they're using very specific dosing parameters for that. We've also seen that low-dose naltrexone has helped not only these case studies specifically on MS, but we've been able to identify even cancer. And although that's not considered an autoimmune disease, we do see that there are some genetic tendencies toward people being more susceptible to getting cancer. So, and again, is that then considered autoimmune? I'm not a clinician. I can't make that recommendation, but it sure seems interesting how that can be correlated. Low-dose naltrexone doesn't cure anything. It literally tricks the body into performing more effectively along its natural mechanisms to continue to work as the body is designed to improve immune function, pain control, and decrease inflammation. We see that the traditional platform of 1.5 milligram increasing to 3 milligram, increasing to 4.5 milligram is fine, dosed once per day, and that captures about 50% of the population that is going to respond to LDN. But what we also find is that there's a lot of people that perform even better or find that their symptoms are much more improved at a dose even lower than 1.5 milligram, even down to 0.1 milligram. And sometimes if we slowly increase that dose every 7 days until we reach somewhere between 3 and 4.5 milligram, we see even better successful outcomes. Patients report that they have less pain, less inflammation, they have more energy, they have better sleep patterns, that they are less tired, they feel better overall. They're able to function cognitively as well as physically. But what's also very interesting is that sometimes twice-a-day dosing is used, and that's specifically for chronic pain issues, but tends to work well in a little bit of the population. Again, that percentage of the population is identified based on what isn't working with once a day. Now, there was a study done through a major university on Oxytrex, which was a small dose of naltrexone, microgram dosing of naltrexone and oxycodone put together. Now, we normally say that naltrexone should not be used with opiate-related pain medications because they basically bind the same receptor. But what we did find is that in the Oxytrex protocol, And through that study is that people who were addicted to opiates were actually able to relieve themselves of that habit and decrease their need for overall pain medication with the microgram dosing of naltrexone. And we call that ultra low dose. And that tends to help many, many, many people. We have helped, my pharmacy and I have literally helped people with 15-year habits of opiate addiction get off of their opiates. And these individuals need to be motivated to do so. But we're talking about medication that does not have a street value and has actually improved overall lives. Now, that doesn't relate directly to autoimmune disease, but it does relate to some of the issues that can happen because of autoimmune disease. Often people with autoimmune tend to be prescribed pain medication over time, and a lot of times they become addicted to it and they're not happy about that. So there are ways to decrease that habit need and improve outcomes. So what we really take a look at is, I'm going to go back a slide here because there's a couple of questions here, is that we try to make sure that we fulfill the dosing specific to that individual's need. And the other question that comes up quite oftenly is, well, I have to take LDN all of my life. Well, that really kind of depends. What we have seen is that most people who are taking low dose naltrexone for autoimmune disease, if they do stop it because, well, maybe they're just feeling really good now and they don't think that they need it anymore, or maybe they go on vacation and they forget to bring their medication with them and they're off of it for a week or two, you can literally abruptly stop low dose naltrexone, but all the benefits then go away. It doesn't necessarily build up to steady state in the body because it only lasts in the body for about 4 to 6 hours. And when it's taken once a day, it will never reach a steady state level. So it does disappear in the body. But we need it to do that so that we can have an impact on endorphins. What we find is that if we, if we keep the medication, if we keep naltrexone in the body 24/7, we do not see the impact on the modulation of the immune system and the endorphin receptors as if we just give a little bit of low dose naltrexone once a day. Then we can actually measure that and we see that impact happening, but we don't see it when we have a constant amount of medication on board. So that's why we usually don't use low dose naltrexone any more than once, maybe twice a day or every 12 hours. So will you have to take LDN all of your life? Well, it kind of depends on how quickly that autoimmune issue goes away and how you're able to perhaps change other areas of your life to make a more positive impact on the disease. But like I said, you stop LDN, all the benefits go away. So therefore your previous symptoms will probably come back that are associated with LDN. Of course, we can also compound a wide variety of other treatments used for the symptoms associated with autoimmune disease. A lot of times with autoimmune disease, we see changes in innervation of the bladder, muscle stiffness, sexual dysfunction, and of course, we can also compound hormones as well. And these are just a couple of examples of some products that we have used specifically for individuals who also are taking medications for a variety of other autoimmune disease. Estriol, so if we go back to multiple sclerosis, estriol and biotin have been prescribed in very large doses orally and have had really great outcomes associated with symptom control with MS. Of course, anytime that we have biotin on board, we've got to be very careful about thyroid function because biotin can artificially elevate TSH. And so we don't want TSH to artificially decrease TSH. So we don't want TSH to look normal when it's not. And that is, we need to be very, very careful with that. Of course, a lot of people that have autoimmune disease have gut dysregulation and often need digestive enzymes. They reduce stress, they reduce inflammation, improves digestion of food, increases nutrient assimilation from meals, supports a healthy microbiome balance, also reduces food sensitivities and allergies, and reduces autoimmunity specifically. Of course, digestive enzymes do decrease its production over time. So as the body ages, that will also decrease the production of digestive enzymes, whether it's happening in the bile duct, around the liver, pancreas, etc. What we also know is that digestive enzymes do improve skin and tissue healing. So there's a variety of things that patients can do today that even providers can do to help support their patients. And that's taking a look at some of the very core basic functional medicine areas, such as what is your vitamin D blood level? Is the patient sitting in front of you taking multiple vitamins, B complex, fish oils? All of those are very supportive in managing autoimmune symptoms and autoimmune disease. Magnesium is very calming. It's a natural muscle relaxant. It helps to regulate blood glucose level and is mandatory in over 400 chemical reactions in the body. However, many people are magnesium deficient. And magnesium and vitamin D do have kind of a love-hate relationship there as well. So people that are taking huge vitamin D doses tend to have lower magnesium levels. Magnesium glycinate tends to heal the gut and soothe the gut a little bit more than the other forms of magnesium. And there are some forms of magnesium, such as glycinate, taurate, malate, that tend to have less side effects, so less constipation and or diarrhea, and certainly less gas and bloating. And then probiotics to help nourish the gut, to squeeze out the bad guys, to repopulate the good guys are also very important. But exactly how do you introduce those? Do you do them every day, every other day? And at what point do you then increase them? And when do you add a prebiotic? Do you add something as a mucosal lining repair as well? There's a wide variety of health professionals that can help you pick out the right probiotic for the given situation. And of course, if you're doing any kind of gut testing, a lot of times the lab will also help associate a good probiotic routine. Maybe that includes a prebiotic and a mucosal repair product as well. But that can also be very helpful in understanding what is necessary for that given time. So, long before this pandemic and everything came to us via Zoom, we had a wide variety of virtual teachers, and I'm very happy to be a part of this crowd. I thank you for joining me. This is a website where you can find me and my handles on social media, as well as LinkedIn. This is the network of pharmacies that I am now associated with, and I'm very thrilled to be associated with all of these pharmacies. Everyone seems to have very good networking and good knowledge base. So if you can't get a hold of me, you're welcome to reach out to them as well. I'm also known as the LDN Pharmacist, and you can find me on my Facebook page, website, as well as this is my personal email address, mmoser@revcustomrx.com, and my personal cell. I look forward to hearing from you. Please reach out. And thank you for joining me, and be well.